So I think we'll go on to our next speaker, and we have Dr. Shreyas Ramamurthy, who's, I will no longer call him the youngest because he's very experienced, but still a young, brilliant surgeon. Speaking on phacoemulsification in hazy corneas, he's also a brilliant cornea surgeon, so let's hear it from him. Your mic needs to be switched on.
Yeah. Can you? Hello? Yeah. So thank you so much, sir, and I thank Dr. Maipal, Dr. Hemlata for having me in this course. And today I'll be taking you all through some videos of phacoemulsification, hazy, compromised corneas, and each video is going to be different from the other. And I will try to drive in some take-home points with each of these different surgical situations. First is a common setting of cataract in a case of trauma, where you can see a corneal tear repair has been done. It's important that we wait till the corneal sutures have been removed and the wound is stable before we go ahead with the cataract surgery. Very often you will find fibrotic membranes, synechiae which have formed, which need to be dealt with. You are likely to have, when you have a trauma like this, the injury might extend even up to the PC. So no hydro dissection is to be done. I'm just slowly teasing out. These are generally softer cataracts, so you can just tease out the material and always be keep the chamber stable. In this situation, the PC itself had not extended, and there was sufficient anterior capsule leaflets for me to cover and put the IOL in the bag. But in often situations, you may not have that, and you may need to keep a 3-piece IOL standby where you need to place it in the bag. Another situation where you have surface issues along with cataract surgery. This is fairly common. What I'm showing maybe here is an extreme scenario where there's a Steven Johnson syndrome patient who has come with a mature cataract patient who was actually referred for cataract surgery. But if you directly go ahead with the cataract surgery in these patients, you will end up with desiccation of the epithelium, subsequent corneal melt, inability to heal, persistent epithelial defects, and then perforation, and really compromises the outcome. So stabilizing the surface, either using a combination of techniques, using a mucous membrane graft, using amniotic grafts where necessary, using adequate immunosuppression, because OCP is another condition which is very commonly present in this age group along with cataract. Patient may present with the cataract, unless we evert the phonesis and look for symbolifera, we may miss it. So it's important that we stabilize the anterior surface before we go ahead with the cataract surgery. The cataract surgery, some minor modifications may be necessary because the phonesis may not be formed. You may have to use sutures to retract the eyelids, traction sutures, and then doing the chopping maneuvers, do it away from the area of opacity, tilt the globe downwards. Rex is also to be initiated away from the site of opacity and to be finished. I will show it in subsequent videos also, and then use a 3-piece IOL. Always prefer to suture these corneas because the tensile strength of these corneas are much weaker than the regular patients, and therefore even if it's a good wound, better to suture the main incision. And subsequently the patient will have good outcome, and you can also do scleral contact lens fitting subsequently on this, and gives an excellent quality of vision even in these difficult situations. This is another situation which I think Dr. Hemlata also showed very elegantly. It's a failed graft, and you can, to improve visibility, you can debride the epithelium, you can use glycerol to temporarily deturgis the stromal edema and improve visibility, and then also use chandelier illumination. The reason that it becomes even more important in combined cases is because doing a safe in-the-bag phaco, being able to implant an IOL in the bag is extremely important for the subsequent endothelial keratoplasty that you're going to do. If your IOL is unstable, then the subsequent EK procedure becomes even more difficult. Your air bubble maneuvers become difficult. The bubble tends to go behind the IOL and push the IOL forward and the iris lens diaphragm forward, making the entire surgery a lot more challenging, a lot more messy. So in these situations, it's good to go ahead. I will not show the dissection part, but now since the IOL is in the bag and nicely stable, all these maneuvers which I'm doing becomes a lot more easy, and you can go ahead with a tight fill and have excellent outcome in these patients. Definitely suturing all the ports, including the pars plana ports, becomes very important because you need a tight fill to ensure that the graft is adhering very well. I'll show you a couple of situations where you don't want to combine with a transplant. This is a patient with adherent leukoma. This is adherent leukoma which the patient has had since birth. So it's not really the visual compromise which has happened now is because of the cataract which has developed. Doing a PK will not improve the vision. Not only that, these patients are notoriously likely to have neurotrophic corneas where the epithelial healing can be poor. So basically what we are doing is tilting the globe away. I'm using a superior incision, tilting the globe downwards, doing just simple chopping maneuvers. Each time I chop, rotate the nucleus, bring it into the area of visibility, chop again, and then emulsify. So the inferior half may not be visualized, but the superior half can be visualized, and you can do a safe phacoemulsification by tilting the globe downwards, and then keep a IOL in place. These patients will go back to having the best corrected visual acuity that they have maintained right through in their life, and they will be quite happy. Doing a PK can have disastrous results. Another patient with a 71-year-old male, one-eyed patient, other eye is already a failed vascularized graft. This patient presented with a neurotrophic cornea, had a secondary bacterial infection. He resolved after AMG, antibiotics, steroids, and then had this significant scar. Now, very often in these patients, because they are one-eyed, they have delayed presentations, they don't present for their cataract surgery very early. So you have the double challenge of having a compromised view, but also a significantly hard cataract. So one thing which we must ensure, like I mentioned, is that we have a sufficiently large rhexis, so that if at all you have to prolapse the nucleus out, convert to SICS, that will be possible. Initiate the rhexis away from the area of maximal scarring and complete the rhexis in that region, so that you know that you have an intact rhexis. Subsequently, all your chopping maneuvers, again, slightly tilt the globe into the area of visibility where I can see the crack going right up to the periphery. And I should ensure that I do multiple cracks, multiple chops, and that the nucleus is completely separated. Because if the nuclear pieces are not completely disassembled, completely separated from each other, and there are even tags, while trying to emulsify them, I will end up pulling more of the nucleus, which can compromise the bag's strength, cause zonular dialysis, and this can become even more difficult when the view is already compromised. So it's important that we crack the hard center, do multiple chops, and then subsequently only when the center is cracked and I know that I have multiple small pieces, will I go ahead with the phacoemulsification. And once that can be done, you can then emulsify as you would normally. Just be careful that you're again doing it in the area of visibility. These patients, although they have scarring, their endothelium itself is not really compromised, and you can go ahead with a very safe emulsification and end up with very good results. The idea is not to really deliver 6/6 results. It's to ensure that the patient has a 6/36 or a 6/60 for the rest of their life, rather than have a 6/9 for just a year or so and end up with a failed vascularized graft like the patient has in the other eye. This is another situation where the patient, after a therapeutic graft, had an intermittent cataract, 360-degree synechiae, and high IOP, which was leading to a corneal edema. Originally, I thought I may have to do a combined surgery. But as I was doing the surgery, I realized once I decompressed that the corneal edema was coming down. It was also partially IOP induced. It was early postoperative period. And I just went ahead with a plain cataract surgery in these cases. So very often, once you remove the cataract, the IOP stabilizes, the inflammation reduces, this cornea will stabilize. And this patient for the next 5 years did not require a graft and was able to manage with that original penetrating graft itself. And only later, after 5 years, it decompensated when I went ahead and did a desec at a much later stage. Thank you so much for your kind attention.
Thank you.